The next section is the first of our two sections on pulmonary function testing. In this section, we're going to talk about spirometry, probably the most elemental and simplest pulmonary function test, but it's an important one that tells us a lot about lung disease. In the next section of our pathophysiology review of the lungs, we're going to talk about spirometry, or pulmonary function tests. There are two main patterns of lung diseases. There are obstructive diseases, where we see reduction in the flow rates, the lung volumes are generally increased. Examples of this are asthma and COPD. Another example might be cystic fibrosis or bronchiectasis. The other major pattern of pulmonary disease are restrictive diseases. Now, there's no problem with airflow in these diseases. The problem is that the lungs are too small, that the lung volumes are reduced. Examples of this are pulmonary fibrosis or IPF, other interstitial lung diseases. Obesity also will present as a restrictive problem on pulmonary function testing. The first pulmonary function test we're going to talk about is spirometry. This is the simplest pulmonary function test to perform. To do this, you can see from the slide, someone has their nose clipped and they breathe in and out through the spirometer. So all the air that they either bring in or blow out is going to be measured by that spirometer. We can measure the air that they bring in or blow out, and then we can also measure the rate at which they bring air in or out. This is referred to as the flow rates. We can display the data from spirometry two different ways, either as volume over time or as flow. When we do spirometry, we're going to get three important values when we measure the volume over the course of time. We get the forced vital capacity. This is the vital capacity that we talked about in lung volumes. But because, remember, we've got that PFT tech sitting there next to us yelling at us, it's a forced vital capacity. The FVC can further be broken up into the FEV1, or forced expiratory volume in 1 second. This is the volume of gas that you exhale in that first second of forced exhalation, or the FEV1. We can also look at the ratio of the FEV1 to FVC. What percentage of gas during a forced exhalation do we breathe out in the first second? For a normal person, the FEV1 to FVC ratio should be about 75 or 80%. A lot of times you're going to see graphs on the step 1 of the boards or even later in your testing. Physiologists especially love graphs. In pulmonary physiology, there's a lot of different ways to express the same spirometry testing. I think it's important, if you see a graph on a shelf exam or on the USMLEs, not to freak out, just to look at what the graph is trying to show you. There's a lot of different ways you can graph the same information to convey the same principles. In this graph, we have lung volume on the y-axis with time on the x-axis. So this graph is just showing the volume of gas that you blow out as a principle of time. This is a normal spirometry. You see someone's having normal tidal breaths, and then they take a deep breath in, getting all the air in the lungs that they can, and then blowing out everything that they can. And that sharp descent is the forced exhalation. Now, the difference between the lung volume at the beginning of that and at the end of that is the FVC. Here it's recorded as 4 liters. Now, because we don't know the amount of gas that's left behind in the lung, we don't know what the total lung capacity is. Because we don't know that residual volume, how much gas is trapped behind, we don't know what the total lung capacity is. So we really never really know what the total lung capacity is when we do spirometry. We can look at how much of that gas was exhaled in the first second. So if we draw a line marking the first second and look at the lung volumes at that point, we can measure the FEV1. And the FEV1, or the FEV1 to FVC ratio, is important, especially defining obstructive diseases. As I mentioned, a normal FEV1 to FVC ratio is about 75 to 80%. Typically when this is tested, it shouldn't be 74%, defining as abnormal. In fact, your FEV1 to FVC ratio will go down as we get older. So we have a tendency to look like we've got obstructive lung disease with a low FEV1 to FVC ratio as we age. Obstructive diseases, one of the cardinal pathophysiology examples of lung disease, is defined by a reduced FEV1 to FVC ratio. If you've got obstructive lung disease, you by definition have a low FEV1 to FVC ratio. That's going to be associated with a low FEV1. The FVC, the forced vital capacity, can be normal or it could be low. Sometimes it's even elevated. Restrictive diseases, however, can only be suggested by spirometry. The FEV1 and FVC might both be low, but typically the FEV1 to FVC ratio is normal, or sometimes even a little high. You can see three different examples here in the graph. Somebody with emphysema, a typical obstructive disease, has a low FEV1 to FVC ratio, 38%. The person with normal lungs has a normal FEV1 to FVC ratio, and an FEV1 to FVC ratio of 83%. The person with interstitial fibrosis, an example of a restrictive disease, has low lung volumes. They've got a low forced vital capacity, but the FEV1 to FVC ratio is normal at 83%. This is an example that restrictive diseases might be suggested by the spirometry, but you can't confirm it because we don't know what the residual volume is and we don't know what the total lung volume is. Here's an example of the same spirometry information shown with a different graph. Once again, time is on the x-axis and volume is on the y-axis, but this shows a positive deflection for exhalation. We could take the slope of this line at any point, which is the change in volume over the change in time, and the slope at any point defines the flow. In this next graph, we show what's called a flow volume loop. Now, just by convention, exhalation is positively shown because it's air that's going out of the patient into the spirometer, and inhalation is negatively defined because it's air that's going out of the spirometer into the patient. A normal flow volume loop is different than the spirometry tracings we were looking at before. This shows that the maximum flow occurs during the earliest part of exhalation. This data was generated from the same way. We had a patient do a normal forced exhalation. The inhalation is shown and then the forced exhalation is shown. So with one measurement, you can get data graphed either the way we did in the previous slide or look at the slope or the flow and graph the data as we are in this example. Obstruction represents impedance to airflow. It's an expiratory process. So anybody with obstructive disease has problems getting air out. The hallmark of this, as we said, is a reduced FEV1 to FVC ratio. How low your FEV1 is defines the degree of impairment. We can show that obstructive PFT also using the flow volume loop graph. In this case, instead of having a normal looking flow volume loop with high flows early in exhalation, we see a scalloped, or what Dr. Thwaites likes to call a toilet bowl shape of the flow volume loop. Now, I'm a lung doctor and I like to keep toilets out of my talk. The reason I went into this is to keep it above the diaphragm. But we can see on this graph at each of the different lung volumes, the flow is lower. You can also see this if you measure a peak flow by a handheld device. Somebody with asthma might be familiar with a peak flow. A peak flow meter is something you might use in an outpatient setting, you might have the patient take home, or you might use it in the emergency room. And all the peak flow meter is measuring is the max flow you can get during exhalation. it's obvious that this patient with the flow volume loop shown in the graph is going to have a lower peak flow than somebody that does not have obstructive lung disease. The flow volume loops for restrictive diseases should look pretty normal. The only thing you might see is that because the total forced vital capacity is lower, that graph might actually be narrower. The shape of the flow volume loop might actually be a little bit narrow. And just to drive home this point again, we can suggest restriction based on spirometry, but to confirm it, we need to measure lung volumes. Here's an example. Somebody comes in with shortness of breath, dyspnea. We do pulmonary function testing, and we see that their forced vital capacity, their FVC, is 96% of what we would predict. Their FEV1 is 88% of what we would predict. Their FEV1 to FVC ratio is 81%. And we look at their flow volume loop curve, and this is a normal looking flow volume loop curve. We'll actually give further information and say the lung volumes are normal. So what's wrong with this patient? Which of the following statements are true? Is the pattern consistent with obstruction? We don't see a typical obstructive, scalloped, toilet bowl shape to the flow volume curve. We don't see a low FEV1 to FVC ratio, so no, this pattern is not consistent with obstruction. Is this pattern consistent with restriction? We see normal forced vital capacity. We even see normal lung volumes. So no, this is not consistent with restriction. This is actually a normal study. This is a good example. Not everybody with shortness of breath has abnormal pulmonary function tests. There's a lot of different things that can cause you to be short of breath. Many problems that are even outside of the respiratory system. Heart problems, blood problems like anemia, even psychogenic problems. People may manifest anxiety as feeling shortness of breath. Pulmonary function tests are useful because they define what's going on in the lungs, but there's a lot more to shortness of breath than lung volumes or even gas exchange, that we'll talk about later. Here's another example. Which of these flow volume loops represent obstruction? In this flow volume loop, the patient has normal high flows during exhalation, compared with this patient that has low flows during forced exhalation. So this patient is the one with the obstructive pattern on flow volume loops on spirometry. The other important thing about spirometry is forced exhalation is an effort-independent process. So if we had the same patient do 3 different tests, first time we had him or her give maximum effort, the next time we have him give kind of a medium effort, maybe not try quite as hard to blow all the air out, and the last time just do a very erratic or very weak effort, we'll see that for each of those times we might see a lower peak flow, but we'll never, the end of exhalation is effort independent. And it's important because the end of exhalation is a process of airways collapsing, this process of dynamic airway collapse. So no matter whether you're faking it or whether you're trying your hardest, that descending portion of exhalation will always look the same. That is not an effort-dependent process. And this can be important as we try to interpret a test to look to see if someone's trying their hardest. That concludes this section about spirometry. Obviously, we've left out how to figure out what the patient's total lung capacity is. We'll talk about that in the next section about measuring lung volumes.